I wanted to start with really the title and ask the question, how do we know something, or how are we sure that we know something? And so writing about the physical sciences a few years ago, Maddox, who was the editor in Nature, came forward and he said, theory or thoughts about something really qualify as explanation if you can and you have actually tested it by observation and experiment. And in this kind of day and age where we like to control things, it also helps if we understand the mechanics by which things work. And so if you look back over the last 50 years of health services research, health policy, and a whole sort of line of inquiry in this area, you start to say, okay, there's been an explosion of knowledge, but how much of it do we actually know as opposed to kind of think? And when you look at it, there's been remarkable advances in analytic techniques. You can think about real-world trials. Been remarkable progress in synthetic techniques like cost-effectiveness analysis or consensus panels. But most of what we know that would pass the test put forward by Maddox actually have to do with program design. Those things that we can break down nicely into discrete units, test, observe, experiment, and reproduce. And a lot of the things that we talk about in health policy, we actually don't know in terms of that sort of very true test. As you start to look at it, all of these sorts of insights coming along, it's a treasure chest full of ideas on how to make health systems better. But it's much more of a list than a strategy. And it's not surprising when the Drummond Commission comes out with over 100 recommendations in Ontario on how to make the health system better, that it ends up looking like a list that no one is really sure where to start, nor sure how to prioritize. And so Michael's right that the same recommendations show up time and time again in different reports. But that's in some ways because it is an almost undoable task to satisfy all of those. And I'd say that the challenge in all of this is that faced with this list, thoughtful people instinctively say, well, it's complicated and it's going to take a long time. And this is where I'd like to start my list of what I think needs to be discovered. It's complicated, and it's going to take a really long time. So that seems like a very honest and appropriate statement that we make. And it's also the surest way to make sure that nothing happens. If you go to a busy person running a ministry or running a hospital or running a health region or someone trying to innovate like mad and act entrepreneurially within our system, if you look at them and say, it's complicated, what you're really saying is, you're likely to fail. And if you say, it's going to take a long time, what you're really saying is, and by the way, we'll all be around to congratulate your successor. And that's a great way to turn people off at change. Now, how do we actually sort of get past this? Tom Lee the other day, who's the CEO of Partners in Boston, the aggregation of Massachusetts General and Brigham and Women's, said in kind of the shorthand through the last 10 years of Harvard Business School in healthcare, he said, oh, we've got a Porter strategy, we've got Gowande tactics, and we've got Boehmer operations. And that was a very nice way to sort of shorthand a whole bunch of bright people who built on a whole bunch of other people's bright people's work. But what he was really saying is, we focus on measures that matter to patients, and only that now. We use really simple tactics about how to improve things like checklists. And by the way, we build a relentless culture of improvement. And if you look at that, I think that's actually in some ways one of the secrets to how you actually get going faster. And it's about having a set of outcomes, and I'm going to come back to this issue, that everyone thinks are important and that are reassuring and restoring and re-energizing. It's about taking all the things that we really do know now, because you know what? The tactics are the things that we figured out. Not necessarily the strategies, but the tactics. And you start to measure things that change quickly. John Frank in the Millbank Quarterly, and I got to see it in person at St. Mike's the other day, has taken this task head on, and he said even when we're looking at the social determinants of health, these broader determinants of health, these things that seem beyond anyone's individual grasp, there are things that we can measure. Things that are meaningful, things that link into ways of improving, and things that change quickly. And so I think that's where I sort of want to end on this, but as you think about this idea about fast implementation, I actually think this is as important an element for the new SPORE program as any attention to KT. Not just how do you transfer the knowledge, but how do you bridge the gap to implementation and bridge it in a way that's quick and leads to results that matter to people. So the second item, and this will sound funny coming on the heels of Zeke Emanuel's talk about how big the health system has gotten in the United States, and we all know that at least pound for pound, we're doing our best to stick up with that as well. But I think the next challenge is how to get the health system bigger. Not talking about consumption. I'm not talking about spending more. What I'm talking about is expanding the value chain to bring in the groups who can really start to affect the change that we want to see in our system. And so whether this is the people who do contribute to the broader determinants of health, or it's caregivers, or the single largest number of participants in our healthcare system, we need to figure a way to re-engineer the system so that it includes them. And so that when we're talking about, for instance, in Ontario healthcare policy, we're not talking about 25,000 doctors or 150,000 nurses, or the roughly 500,000 people who work within our system in that province. We're actually talking about 13 million Ontarians who one day or the other will actually be working largely informally within our healthcare system to take care of the people that they love. Now, the integrator models that are developing in Wisconsin, where they've actually kind of taken a corporate approach to broader determinants of health, are interesting. So are the new ways of looking at technology to engage caregivers that are really redefining community in a way that I think puts the old sort of bowling alone stuff a bit to shame. But all of these are also going to threaten roles and responsibilities in our system as we start to reallocate resources. And so I'd argue that something we really have to figure out within our system, as we get it bigger, is how we turn this into a win-win, or something that actually grows the system in a positive way, rather than just the same old sort of tired discussion about who works for whom, who has power in our system, who gets to do what. The final thing I'd like to talk about, I think we need to discover, is how to stay the course. We've become really good in health services research and health policy research at talking about what is important, at different ways of setting priorities. What we've never figured out is how to get people to adhere to those priorities. And this is in part probably because healthcare is always, and rightfully so because of how important it is to us, it is always a political decision. And when you make a decision, it is often a decision not just about what to do, but it's a decision in favor of change. And it's often a decision about what to refuse or what to say no to. And those are hard political states. But in the absence, again, of those high-level goals and a small, coherent set of high-level goals for what we want to see in our system, it's hard to make a decision. And not surprisingly, each new announcement isn't about reinforcing a broader pursuit of a healthier country or a more sustainable system. It's about an additional program that sits beside another program, that sits beside another program, that sits beside another program. And so I believe we do have to figure out how to go faster. It'd be nice to figure out how to get bigger. Might be a nice tonic to the usual discussion about how we need to get smaller and why we can't. And I think we need to figure out how to stay the course. And those will require an interdisciplinary approach, a body of theory that is very different from anything that we've encountered before, and a much tighter connection, I believe, at the end of the day, fundamentally, and a real connection and a real relationship between the production of evidence and the use of that evidence that goes far beyond the usual passive KT. I think it also, as you look across all of these things, it has to start with a plan and goals for our system. And I believe it's been clear, this is something I think we are increasingly at least observing, if not experimenting with. But when people have a plan with goals, when they report against those goals, and when they engage clinicians, wonderful things happen. When those things are absent, we have that same passionately cynical discussion about healthcare. We know what to do. Why aren't we doing it? Well, we're not doing it because we haven't said that's what we're going to do. And we have no way of knowing how we're making progress. And so those big three questions, I think they're great, faster, bigger, and more true to course are the things that I'd say left to be discovered. Thank you.